be going live in a bit, and what you will have today is two amazingly cool clinicians who have been doing something a bit more than just clinical dentistry. I know both Ian and Barry have been in practice at the coalface, really having a great few years of experience in all types of practices, from the NHS to the private practice. Ian has done a few MSCs, I think, because he was doing an endodontic MSc. He's done his MSc in acute pain management as well. And it's really, really cool to see how everything is coming in together. Ian has always had an interest in endodontics, in pain management, in helping patients. And interestingly, Barry's had the same interest in trying to make life very comfortable, getting the patient to come and see the dentist regularly and feel happy, feel comfortable, feel really proud to see the dentist. So, two amazing clinicians who we're going to welcome soon on Tubules Live Aid, or Tubules Live Together, I should say. But before we do that, I really want to show you this amazing new video that's come in, I think, today, if I'm not wrong. Well, that was us on screen. A new video that's just come in today from our media team. Enjoy it because it carries an important message.
Isolation doesn't mean loneliness.
Uncertain doesn't mean unpredictable.
Challenges mean opportunities.
Time out means a time to reflect.
A time to come together.
A time to work together.
A time to support each other.
A time to inspire each other.
A time to change the way we think together.
A time to learn new things together.
A time to educate each other.
A time to gain personal mastery.
A time to gain financial mastery.
A time to gain clinical and professional mastery.
A time to believe.
Believe that together we will come through this.
Believe that a restart will reignite a new beginning.
Because when we work together,
we will
motivate, grow, thrive together. Dentistry together.
Two lives together.
There you go, Tubulites together, Tubules Live together. It's about coming together to really uplift people, boost people, get this moving in. And that's what we have done for the last few weeks. We've covered topics covering personal mastery, financial mastery, professional mastery, giving you all the skills you'll need to get, off the blocks once we're given the lockdown release date. Today is brilliant because I think we're bringing personal and professional mastery together. I'd like to welcome two guests. Let's first welcome I don't know if I'll call him a guest anymore because he's part of the family at one level. He was here last week and he has become more or less a fixture in the Tubules Live Together real good things we've been doing. Welcome, Barry, again to Thursday night. How are you?
I am blessed to be called part of the family. I'm really good. Thank you very much.
And how are you enjoying it? Because I think every Thursday evening we've managed to get you locked in your shed, staring at us and talking about all these amazing things. Your talk last week got lots of amazing and positive feedback. I mean, people wanted CPD for it too, so it must have been absolutely brilliant. One person said, after listening to Barry's talk, I've realized I was looking at things the wrong way. And you've changed somebody's lens properly.
Yeah, it's a reboot, isn't it? It's you see, anything that I share, as you know, having been on the course, is stuff that people already know. It's just making them consciously aware of it so that they can then choose to do it on purpose. And on purpose is a great word because we use it all the time, but actually it means there is a purpose to what we're doing. And so I love sharing this stuff because then people pick it up and go, actually, flipping out, yeah, I could do that. And changing the language in your mind changes your reality, as we found out last week.
I think it completely does, and it's changing people's realities. And on that note, I'd like to welcome today's, I wouldn't call him a guest either, because Ian's been part of the Tubules family for years. He was and was a study club director for the South Kent Study Club. And every time I've spoken to Ian, you've managed to tickle my grey cells and get me thinking. Ian, one of the funniest stories I have is, remember we went to, I think it was BSRD or a dentistry show in Birmingham.
Yes.
I'm someone who loves traveling economy, so do you. But that day, both of us ended up on Virgin first class by mistake. Sat there.
All right, too.
The ticket guy came along. He said, "Do you want to upgrade?" Yeah, go on then. Actually, Barry, we learned that if you sit on a train and then do the upgrade, it's cheaper than buying the ticket. Because
yes.
we both did a first class upgrade for 20 quid and got a free sandwich. So Ian's got lots of skills. And Ian's on Stone Rock Dental Care as well. You are one of the clinical directors in Hawksworth as well. How's well, I wouldn't ask you how's practice going, but you're doing a MSc in acute pain management.
Yeah, so just to correct on that, I didn't do an MSc in endo. I did a diploma in restorative dentistry, and I worked in endo at King's in the mid-90s with sort of giants of the game. Sort of Martin Kelleher and Pete Briggs were kind enough to spend some time with a utter nobody like me. And fledgling giants at the time, Richard Porter as well. It was lovely to work with him and see him become such a huge name and influence in dentistry. So my endo background is sort of 20, 25 years, really. It's where I've tried to focus. The MSc came along just by happen chance, and I wanted to take my studies and knowledge of acute pain management a little further, so did an MSc project in it, and that's getting finished up in June, along with my expert witness certificate I'm doing through Cardiff University as well. So
you don't have any time then, Ian.
No, I was quite glad the practice shut down, really. I was knackered.
Can I ask you a quick question? Are you exclusively doing endodontics now?
No. I never wanted to do that. I enjoy too much of other aspects of dentistry. So I think general dental practitioners, I have to say, are the absolute giants of dentistry. You know, we tackle so much in every day that you know, I really didn't want to lose those aspects. So I never wanted to stay in one field all day. I'm not being dismissive of Drew's specialist efforts, but
no, but I totally understand. You've got to have some serious nettle to be doing one thing again and again, invariably.
Yeah. So no, I don't do. I suppose it's about half my day. Is probably how it works out. About half my day. It has been for.
So why and how did you end up learning about acute pain management, and just really how did you end up going down this route?
It's a topic that has always fascinated me, in you know that whole thing of, you know, why does pain hurt so much? You know, there's a you know, in I don't know, Barry's very familiar with the gate theory. You know, you've got that nociceptive level where something is stimulated and we know there's injury and inflammation. Why do we have to have all the rest of it? You know, why does it all? Why do we have to have such severe pain? Why do we have to have a chronic pain? And you know, I've always just, and having managed to squeeze out not one but two of my discs out my lower back in the last 20 years, I've managed to enjoy the pleasures of severe, acute, rapid onset pain. And you think, yeah, okay, I get it. My back's injured. Well, I don't need to know this now at this level continuously for days and days and days. And so I just, you know, got interested in pain and pain management, and just, it's always been an interest. It's always been there, really, from very early on in dentistry. You know, why does this hurt?
I mean, we've got to say, at this point in time, it's not the easiest. A big salute to all the dentists who are trying to go through this really strange waters of patients calling in, and you say, actually, I'm not allowed to see you, and patients are in pain. Some urgent care setup has been done, and they're trying to work through this to minimize as many aerosol procedures. But patients are in pain at different levels.
When it was first suggested that we treat toothache over the phone,
yeah,
I mean, my initial sort of fairly reactionary knee-jerk response was, that's just placebo for the dentist. That's just to make us feel better. But actually, once you pay a little bit more attention to what that phone call can mean, it actually becomes a very valuable service, and much more important than just telling patients to take painkillers, which, as we were just saying earlier, they'd figure that out themselves. They don't need 5 years at dental school to work out to take painkillers for toothache. What they need is a better understanding of why they're in pain, what's likely to happen with the pain, and how they can help themselves. And those are the bits of that phone call that become incredibly important.
So where do we start? Let's assume, Barry, you're going to be the patient, and you call Ian, and Ian's the dentist. And what's the main thing dentists say? Hello. I mean, patients say. What do you get, Barry, when they call you up? Because I normally get, I've got a bleeding pocket, it's urgent, which isn't very useful. But if you had a care patient in pain, what's the kind of reaction you get?
I'll be honest, I am really blessed. I don't get many.
Yeah.
I've had maybe one call a day.
Yeah.
And most of them are just looking for a little bit of reassurance.
Yeah.
Because everything is low grade, or they fractured a retainer, or simple stuff. And interestingly, I turned 50, god damn it, last week.
Yeah.
And about 2 months ago, I had my first ever toothache. And basically I had forgotten to wear my splint again, god damn it, parafunction, split my lower right 7, and it was horrendous. I have never had pain like it, and it gave me a newfound level of appreciation and understanding for what it might be like for a patient, because I've only imagined it in the past, whereas I actually went through it. And it was I think it was a bank holiday. It was God knows when it was, over Christmas maybe. But I had to actually numb myself and open and extirpate my own tooth, which is not easy. But had I been able to maybe phone somebody and say, can you help me? It just took over my head. It took over my neck. It took over my life for a couple of days, whilst I hoped it would settle, knowing that it wasn't going to.
So in this case, Ian, when you do get these patients in pain, where do you think we start? Because that's what you're saying. Obviously, they'll give you their "I haven't slept all night, doc," and as
I mean, I think
pain I've had in 50 years, or
so I think really importantly, the first stage of that is that triage element of finding out the description of the pain. And Barry and I were chatting earlier in the week, or last week, or sometime, I have no idea, the calendars no longer function. But we're talking about how do we get to understand where the pain is coming from, to get that triage going, to know what's going on. And the phrase that I like the most is, listen to the patient. They're telling you the diagnosis. Just listen to what they're telling you. And you will get your diagnosis first of all, and it's initially wanting to know, is that cracked tooth a pulpitic pain, or is it a apical periodontic pain, or are we dealing with an abscess? And so that first stage of it is that triaging element, to really know what's going on with the patient, and they can very quickly give us some really important pointers. And the most, we know that the more diffuse the pain, the more likely it is to be pulpitic. The temperature-driven pain is pulpitic pain. It's very quick for us to work out that it's pulpitic pain, and then we know that antibiotics are off the table completely. They have no value whatsoever in this discussion. We then can go through medical history with them, work out what's going to be appropriate for them. Ibuprofen was briefly off the table, I think, with COVID. I think from 2 days ago, it's back on the table again now, and the advice is that ibuprofen is appropriate and safe to use for COVID positive patients. So I think we can use that with a degree of confidence. Ibuprofen is our go-to medication if they can take it. I'm one of the people who can't. I can't take any non-steroidal anti-inflammatories. They're just going to bleed out on me. So I'm not in that lucky group that can take them. But if patients can take them, that's our first point of call. And then, you know, that triage conversation is, what painkillers have you taken? When was the last ones you took? Work out their dosage that they've already taken, and then start prescribing an appropriate dose for them.
You made an interesting point there, just saying about if it's pulpitis, then antibiotics are off the table.
Yeah.
We also had the discussion some days ago about the confusion that's out there at the moment within the profession about knowing, particularly now remotely, knowing when to prescribe. You know, I've got to admit that 20 years ago, I think I was more inclined to use a belt and braces approach. Not fully understanding, I'm not saying I fully understand now, but I have a much greater depth of knowledge and understanding and experience now. But 20 years ago, you know, qualified for 3 or 4 years, I was more intent on wanting to look after the patient. And I don't think we were that concerned about antibiotic sensitivity or the possibilities of misusing them. And so I think I was guilty then of signing a little yellow piece of paper when I probably shouldn't. Do you think there's still an element of confusion within the profession about this?
To start off, absolutely, I was guilty of the same, no question. I think there is still some confusion, and I have seen conversations in the last few weeks happening on Facebook of people asking what's the best antibiotic to give for pulpitis, and I think, you know, we've just got to say that it was wrong a month ago when we could work in surgery, and it's wrong now. And as desperate as we are, desperate those patients are, it's still the wrong thing to do. You know, when I was writhing around on the floor in agony with my back 15 years ago, you know, no matter how much pain I was in, it was of no value to me to someone say, well, should we try antibiotics? You know, of course we shouldn't. You know, it's inflammation. You know, if you've ruptured every ligament in your ankle and you're in agony, you know, antibiotics are not going to alter that. And if you've got inflammation in your pulp, antibiotics are not going to alter that. So there is no reason, there's no value, there's no benefit, and there is potential harm. So there has no part to play. And I think we can be really adamant about that to ourselves as a profession and to the patients. It is incredibly tempting to do it, but it's still the wrong thing.
Yeah, because practitioners are very often feel that they're under pressure from the...
Absolutely.
So it might be useful at some point to maybe just run through the language skills that you would use and or I would use to explain that to a patient. Because when you've got a patient who's in pain and they're demanding, I need antibiotics. My last dentist gave me antibiotics.
Yeah.
It's easy emotionally to cave into that. But if you're going to stand true to what we know as evidence-based dentistry, it would be useful, I think, to come up with some options of language of how to explain that to a patient.
Yeah, I know. I think they are, and I think, I mean, I have some fairly stock phrases that I go through trying to pick the right one for the appropriate to that patient. But I think that, you know, that key is that there's a good example of, you know, and these are all just stolen from other people. I'm not claiming any originality here, you know. But that whole thing about, you know, if you sprained your ankle, we wouldn't give you antibiotics, you know, because it is an inflammatory pain. And you wouldn't expect someone to give you antibiotics for that. And it is the same pain that is happening in your tooth. It is inflammatory pain. It's just the same.
As a patient, as a lay person, if I'm sitting there, I don't know what kind of pain it is. I just know I'm in pain.
Yeah.
Patients interpret any pain as infection.
Yes.
And step one is go into the whatever drawer, get the paracetamol out. Things get worse, get the ibuprofen out. Things get worse, I have some cocodamol, right?
Yeah.
Patients
a friend has some cocodamol left from when they had backache.
Yeah, and half a packet of antibiotics that they've got for a skin condition.
Yeah.
And this is how they work. And when it doesn't solve, they pick the phone up expecting you to write a prescription, especially now when you can't see them. And we know it's not going to cure the pain. And I think that the theory now is you've got to triage them. You've got to do AAA at the moment. Yeah. So analgesics, fine. We kind of said to a level it may work. Antibiotics, we know, is going to have limited outcome there. So what?
No, I think we're just going to say not limited outcome. They just have no part to play. They just are not going to help you, and they have the potential to make any situation worse when they're given incorrectly.
Yeah.
I don't go into lengths with patients about antimicrobial resistant infections and the rise of those. But, you know, we do know from good evidence coming out of medicine, you know, which the GPs are to their credit, done huge efforts in reducing antibiotic prescription rates for things that used to, constantly get, trimethoprim for every single UTI, penicillin for every single otitis media, just endlessly prescribing, and they just don't prescribe for them now. And if you look at prescription rates in small localized communities, and look at the AMR rates for those, they track perfectly. If the GP surgeries, a couple of GP surgeries in one village, small population, 5 to 10,000, they start to change their prescription patterns, the AMRs go down, and it tracks perfectly. So we know that we do have a significant negative impact. Now, on an individual basis, the person in pain, they don't care about that. That's a no. There's no point in having that conversation with the patient. But as professionals, we know that about ourselves. If we are inappropriate in our prescribing patterns, we do have an impact on the individual. That individual is in increased risk of AMR for a month after that broad spectrum antibiotic, and as a population around us. And then that feeds back to us, because we live in that population, and therefore we're exposing ourselves to more AMRs. So, I think as a profession, we have an absolute duty and obligation to lower that antibiotic prescription, inappropriate antibiotic prescription. So it's not good to say it's going to have limited outcome. It's going to have no outcome. I mean, in the past, as Barry said, it was belt and braces, and that really just reflected the fact that we weren't confident in our diagnosis.
But where do you go from there when you're between a rock and a hard place? That's the question.
Well, you start with pain relief.
Yeah, and once the pain reliefs come in, I guess pain relief and management is tiered as well. You kind of work out paracetamol first, ibuprofen. What's your thoughts on that?
That's the nice guideline ways of doing things, and to put the paracetamol first. But we know that NSAIDs, dual action on COX-1 and COX-2 is the most important anti-inflammatory part of the whole pain relief mechanism, and paracetamol works much more on the hypothalamus, the prostaglandin release in hypothalamus, which is why it's great for temperature control, but it's not anywhere near as effective for peripheral anti-inflammatory modulation. So if someone's in pain, I don't say, well, let's try paracetamol for a day. I just say, we'll start on ibuprofen, because that's what works. If you can take it, if you don't have any contraindications to taking it, take it. It's the right medication. We don't need to go through. We know they're in pain. We know what the diagnosis is. We're not trying to figure it out as we go along. Someone phones up and says, I'm in agony from my tooth, and every time cold water hits it, I hit the ceiling. I just think, well, take ibuprofen then.
But how long can that go on for? Because invariably the pulpitis is going to become from acute to chronic.
Well, that's what we're finding out, isn't it? We're doing a great experiment in pain experiences. One of the phrases I use to my patients an awful lot is, if you were stuck on a desert island, say, well, if you just couldn't get anywhere near a dentist, you were stuck on a desert island. We've turned the United Kingdom into a desert island, and we are now we're just running this experiment, rolling it forward and seeing how long does toothache last for. I mean, normally it's about 3 days before a patient phones us in pain. So they'll have the first day thinking it won't be too bad. The second day they'll be in denial. Third day is really when they're sort of, this isn't going anywhere. I've got to phone you. So if they don't phone us at that point, normally it's a sort of 3 to 5 day crescendo for the pulpitic experiences. And like most inflammatory pains, you've got about 72 hours where the inflammatory process has to die off. So most people, they're going to go through somewhere between 5 and 8 days of pain. And then it should, for most people, it will settle down. It doesn't normally go pulpitis, AAP, abscess in a sort of boom, boom, boom process. They will have a period of quiescence in between, which is, thank God, because, hopefully that quiescence will last long enough until we open up.
So what we're expecting is phone call at sort of day 3 or 5, because that's where the acute pulpitis is.
Yeah.
And perhaps a phone call maybe a week later, 2 weeks later. And
I think it's really important with the phone call and the triage. We need to be very proactive with it. We need to be following them up.
Yeah.
Be in it with them a bit. Have some skin in the game. My side of the deal, your side of the deal is you're going to be suffering terribly. My side of the deal is that I will at least have the decency to phone you every day to see how it's going.
And so we've got to...
For pampered people like myself and Barry, where we get 1 or 2 phone calls a day, that's very, very achievable.
Absolutely.
Patients, some practices might be getting 50, I don't know, might be getting snowed under with phone calls. It's much harder to do, but
so
certainly...
Does that help? Does that help just because you're providing some sort of emotional, empathic...
Absolutely it does. Yeah, absolutely it does.
And what do you reckon? I mean, Barry, you do a lot about language and talking and saying, and does it have to be as simple as, how is your pain? Or does it have to be deeper than that? Is it conditioning? What's the thought process behind how, when you do call them, they feel reassured, comfortable, and hopefully take it down?
I think it's multifaceted.
Yeah.
When you talk about pain modification, there are certain things that can happen that dial the pain up and their perception of pain.
Right.
And there are certain things that we can do and they can do that can dial the pain down and the perception of pain. It doesn't necessarily change that there's a pulpitis or there's some irreversible pulpitis or whatever's going on, but you can change the pain signal. One of those things is distraction. You hear of all sorts of people that have been playing a football game with a broken foot or broken leg for half an hour, didn't feel any pain, and then they go off the pitch and all of a sudden it's, oh my God, what's been going on? Now, I think when we're in lockdown, there is the potential that people are not as distracted as they normally are because they're not at work, they're not doing their normal routine. And so actually it'd be interesting to see figures on this, not that we'll get them, but it'd be interesting to see if there is an increase in pain perception. So just the fact that you can dial it up or dial it down, the fact that we bother to phone them again and show that love, show that care, show that support, and to give them the sense that there is somebody who's got their back does help to reduce their perception of what's going on. Because very often people in pain are also in fear because the fear of what's next, where's this going to go, what's going to happen. So yes, I think the very fact that they get a phone call has a huge impact. The second thing is the language that we use. If we've got time towards the end, I'll just run through some language patterns. The reason I do that is I don't use words like pain. I don't use, do you remember our model of communication we did last week? That green head and creating an internal representation.
Yeah.
So I want to create a positive internal representation in my patient's head. Even if they are suffering from pain, I want the positive internal representation to be the fact that I've got your back, I'm here for you, you can phone me whenever you want. I've said to every patient I've spoken to, and let's be honest, it's like one a day, but I've said you're at the top of my list. As soon as lockdown is done, you're at the top of my list. We're going to call you and get you in straight away. Now, I've said it to all 10 of them, 11 of them, whatever it is. Yeah. They're all at the top of that list. But the very fact that they're feeling reassured does help to control their anxiety. We know that pain perception goes through the roof with anxiety. We know that people report pain even without a noxious stimulus. We've seen reports on that. I've got some studies on the presentation that I do for Septidon, where they've done research and studies is that, the ISAP used to think that the definition of pain was the potential or actual perception of this emotional and physical response. And they hadn't at that point accepted that it could be an emotional pain even without a noxious stimulus. And now we know that that occurs. They took a group of young, healthy men and they did functional MRIs on their brains, and they stabbed them with a pin and monitored their brain activity when they did that. They then involved them in a computer game, which was very engrossing. And at a very unfair point, they excluded them from the game. And at the same time, they were functional MRIing. And what they found was the brain gave the same response to the emotional pain of being excluded as it did to the physical pain of the stimulus, so that we know the emotional and the psychological aspect of pain is as important as it is the physical response to the pain, if that makes sense.
That makes complete sense. And in fact, this is very interesting because as some questions come in, I'm going to bring this things as well. Shiraz Teja, nice to hear from you, Shiraj. Is there a time scale for an irreversible, kept me awake pulpitis to calm down without intervention? And we obviously were discussing that a bit earlier as well, where you said the first 3 to 5 days of the acute pulpitis, and then they get a period where it calms down. There's a real interesting discussion about this antibiotics and the real challenge we're facing right now. So, someone saying, what dosage can you prescribe for ibuprofen as a dentist? I heard I can prescribe 600 milligrams 3 times a day for irreversible pulpitis pain. And somebody has said that Andrew Prine has said, I've heard the same as Mede. A medical consultant told me ibuprofen 400 milligrams is conservative. So, from a pain relief viewpoint, Ian, what do you think? Is it conservative?
Yeah, I think from the absolute maximum of ibuprofen a day is 3.2 grams, but that does, so that's 800 milligrams 4 times a day. That's if you do the Cochrane Oxford League, pain medication league, 800 milligrams 4 times a day is kind of your absolute maximum. There's no benefit beyond that and going higher than that, and your risks are getting higher and higher. Generally accepted is that the more acceptable risk element is to do 600 milligrams, and you can do that 4 times a day. So the pain relief that has been shown, albeit not with a massive study, but to be the most effective for dental pain management is the 600 milligrams of ibuprofen and the 1,000 milligrams of paracetamol, both given 4 times a day. I would say that that is reserved for very, very unfortunate individuals. It's not something that we want to leave people on long term. And it is important to stress at these times that that is a prescription dose. And we shouldn't be encouraging patients to then just make that their normal dose afterwards. And so that everyone then is just taking 600 milligrams all the time. Because we need to be mindful of the impact of ibuprofen, particularly on cardiac patients. And so our usual caveats for our asthmatics and our gastrointestinal bleeders like myself, and the cardiac patients and kidney problems. We have to be very cautious going to the higher doses of ibuprofen. But if they can take 600 milligrams, then take it.
And I think this is very interesting because what you were saying, Barry, about the emotional support is so important. And in fact, I'm seeing some slide on there which I'm going to refer to, because there is a real challenge here. As Rishi says, even for pulpitis, urgent care centers are rejecting patients until they have been given a course of antibiotics. And I've heard this fairly often, where some patients in pain have been referred to urgent care centers and they've replied back, and I have some email sort of screenshots of just bits of the reply where somebody has said, what do we do? Because the urgent care centers are saying, give them antibiotics, amoxil 500, metronidazole 400, heavy dose, and only then can you refer them back to us in this pain situation. Importantly, what you've just said, Barry, is so key about the emotional and psychological support there as well. And Ian, you have got something to kind of show on a slide there as well. So how does this?
I'll just pick up,
chaps. Can I be a pain? I know this is a pain. Just to acknowledge, it's 8 o'clock.
Oh yes,
Thursday evening, and because we're sharing this, we're missing out on the clapping, and it's just to acknowledge the fact that we are all incredibly grateful for everybody that's on the front line, and even our dental colleagues that are delivering babies, for God's sake, and doing all sorts of things. But apologies for interrupting.
I think I will well spotted on the time.
Reminded. Thank you.
Big hand for our NHS colleagues. I mean, not just NHS, but it's all the frontline people doing it. My gratitude goes to I go in the supermarket and I see these people working hard. These people with everyone around, our frontline colleagues looking after their health, all of them. I think I
fed the bin men this morning. Made them scones, jam, and coffee. Bless them.
Brilliant. I mean, we've got to look after them. So, you know.
So sorry, please do.
No, I think very important point raised.
No, very well raised. Important point.
And good timing. And
Drew,
I will.
Can I just pick up on first on that antibiotic issue? I think we've got to be, firm and stand by our principles here. In that, if you have adequately triaged a patient, made a diagnosis, and have seen that patient is unable to function, the pain relief medication that they're taking is not allowing them to have normal function. You need to get them into an urgent care centre to have that tooth opened up and the pulp removed. And anyone who's handing that back and saying they need antibiotics needs to be corrected on that point, because that is inappropriate care. You
raise a really good point. They do need correcting. How would, assume that happens tomorrow to one of your patients, how would you handle that in terms of one professional to another in a disagreement about protocol, given that, that's a tough thing to do, isn't it?
Well, I don't think it is protocol that they should be having antibiotics. I've not seen that in the standard operating procedures that were handed out yesterday that I read through. That's not protocol. That's coming down from an individual who is misinformed about how they should be managing the care.
Perfect. So referencing the correct information.
Yeah. So I think you've got to start by saying, look, I'm standing by my diagnosis. This is a pulpitic pain that is not in need of antibiotics, is in need of an open and dress. I can understand there's enormous pressure from urgent dental care centres to not see that patient, because that patient really has one course of treatment only, which is to do treatment, to open up. And if it's a valuable tooth, the guidelines are that we should not be extracting teeth that would otherwise be saved. It's not an excuse just to say that we're going to take the tooth out. And so that patient needs treatment, and I understand that that's a huge burden on the urgent dental care centres, but that's not really the patient's fault.
What's on screen that I see there at the point when we're discussing?
Yeah, I was just bringing this up because we were starting to talk about the emotional element of pain, and we were discussing just before about patients saying I need stronger painkillers, and often what they need is, and as you said, they need stronger words. They need the emotive element of that conversation to be handled better, so that they understand that the pain relief that they're taking is the highest dose, most appropriate pain relief for their pain, and will work. And in that Cochrane review that I referred to about the pain leads, that dose of ibuprofen and paracetamol for 100% of the patients, it at least halved the pain. And that's the language I'll often say to people. I'm not going to get you completely out of pain, but if I can get you off the ceiling and get you down to a level where you can function and get some sleep, then that will help you immensely. There will still be pain, but it will, and I know Barry will want to not use that word, and I must admit I'm guilty of using it a lot, because I don't want to talk about their discomfort when they're smashing their head off a wall at 3 a.m. That's, don't want to diminish their suffering in that way by trying to underplay what they're experiencing. But I can, I will say to them that level of medication will predictably at least halve their pain. And that for most people is enough to let them know that they will be able to function. And that's usually what they're looking for and asking for. And that's an important bit to get across. And if you can phone them the next day, and if they're telling you how bad it still is, they just will tell me about the good times. Did you have some sleep? Did you manage to eat something? Those bits are just trying to build on some positives that pain relief did give them, so we can work on that. So the slide I brought, it was really just to do a bit about that talk about the central element to their pain, and that question that's always driven me about why does toothache hurt so much. And Barry was talking about the emotional element, and interestingly, they've done similar functional MRI scans on partners, loving partners, parent to child, scanning the brain of the person who's not in pain but can be aware of their loved one suffering in pain, and their brain pattern, their functional MRI is mirroring that of the loved one who is in pain. Their emotional experiencing of the pain is the same as the person who actually has the pain. So these are individuals who have no pain at all and are being scanned, and all that they're being scanned while they're seeing their partners in pain. it's remarkable to see that the empathetic system there is picking up that emotional element and firing it just the same in those patients as it does for the person in pain. So with dental pain, one of the things we have to imagine, and Barry said when he had toothache, he'd had no pain like it before. And he's right, he's not had a pain like it before, because the trigeminal nerve takes up 50% of the somatosensory cortex. It's half the somatosensory cortex is dealing with the nerve pain from the trigeminal nerve. And if you just think, well, why is a tooth so important? Well, from an evolutionary point of view, teeth are very important. And humans are the only animals to outlive the loss of their teeth. And, the trigeminal nerve protects the mouth. It protects us. It keeps us alive in that respect. So from the weight or the value that the brain applies to the trigeminal nerve is enormous, 50% of the somatosensory cortex. So when that kicks off, it completely engages all of our cognitive thoughts at the higher level, because it is getting absolutely screamed at by the somatosensory cortex, which is where we are deciding what to do about this pain. And in the gate theory of pain, we talk about that sort of nociceptive bit, and then we've got the motivational affirmation bit, and then we've got the central cognitive evaluation bit. And that cognitive evaluation bit draws in so many aspects, because there's no one pain center. There's loads of bits firing in. And of real importance there is the amygdala and the insula. And those are bits that are sort of feeding in every previous experience we've ever had into that melting pot when that is getting fired up. And it is bringing in every pain memory and every unfortunate incident that we've ever had. The insula is guiding the hippocampus to bring up our worst memories, to tell us to learn, now this is what we need to be thinking about. Don't just think about the pain. Think about that day when you were 5 years old and you wet your pants. That's what we should be thinking about now. Those are the bits that are getting fired up, and that for some individuals, that is so much of the aspect of their pain that we are not just dealing with the tooth, we're dealing with a lifetime of and that biopsychosocial, that psychological element, how they handle that. And the sociological element is what society were they brought up in, family-wise and broader society, to express their pain, to handle pain. All of those elements are being drawn together by those parts of the brain, and they, for some people, are creating a perfect storm in their head. And those are the ones who the language of how we deal with their pain and how we speak to them and how we encourage them to take their pain relief, that is so important to them, because they will have the potential to leave themselves with chronic pain syndromes after this event, if they choose to.
So this is really rather important, because at this point in time, what you're saying is because the hippocampus is long-term memory. Right near somewhere there lies something called the amygdala that kind of handles your emotion as well. And all of this is tying in together.
Well, amygdala is sort of emotion and stress, yeah, and it will tell the hippocampus which memories to bring up.
And so therefore, what you have to change is how they perceive things, so the emotion of what they're undergoing. So although there is physical pain that they're getting, which we can't change, we're almost trying to say that if we change a lot of these other things, it'll delay the severe perception of that pain at some level as well.
I think what we're trying to allow them to do is to centrally modulate their pain, to start switching off bits. And Barry talked about distraction, and the bit that's not shown on the brain here, the dorsolateral part of the spinal column, where we've got the first bit of descending inhibition can kick in, where the brain can start to send messages down that's saying, well, I don't need to know that bit now. I've heard enough about that. I'll start switching you off. I don't need to know. And, descending inhibition we have all day long. If we're concentrating, the music drifts off in the background. We don't listen to it. We're not hearing it. We're not hearing what people are saying, because we're just switching off all those other bits of information. And the more we allow individuals to tap into that, and that dorsolateral element is where placebo works. It's where the opioid bits work. It's where cannabinoids work. It's where we can start modulating that the afferent information as it's coming in. The efferent information is going down, and it's starting to turn those signals down. And the more we can allow patients to focus on that bit, then the more they will help themselves. But we can't just tell them to do that. We've got to just broadly distract them and give them a sense of self-efficacy, give them a sense of control, because often they're feeling like they're very out of control.
And what do you use to distract them? What sort of things would be useful? Because in this situation we are now, even if we could distract them for the next couple of weeks in a difficult place, and
I don't think we have to distract them for a couple of weeks. I think we have to get them through short periods of intense pain.
Right. Yeah.
You know, and knowing that they will be able to manage that better themselves. The two key predictors for how people are going to handle pain and whether they're going to go into a prolonged pain experience are catastrophizing, so catastrophic thinking, and self-efficacy. Those are the two things that predict most who is going to go on and develop chronic pain syndromes from previous acute episodes.
So catastrophizing is basically what's the worst that can happen. They'll
focus immediately on the worst. Yeah. This is the worst thing. This pain is terrible, therefore I'm going to die.
And what's the self-efficacy aspect that you can really, they're just predictive that I know this has happened before?
So self-efficacy is someone's ability to feel that they're in control and they have control over their environment, their situation, what Barry is talking about, you know, the patient's sense of control.
And Barry, when you talk about language, this is quite important here, actually, because I think when people are getting phone calls, I think there's a language element we can help them with as well. What would you suggest, Barry? If I said to you, listen, I've got this, you know, patients calling me left, right, center. I'm sending them to the urgent care centers. They're coming back and saying, write the antibiotics down. These patients are calling me saying they're in a lot of pain. It's quite stressful. It's creating chaos for me. It's invoking my pain memories. But more importantly, for that patient, what sort of thought processes, Barry, do you bring out in this case for them?
Well,
and what sort of language, I guess?
Whilst I will have conversations with them, what I hold in the back of my mind is that I am a master hypnotherapist, and I don't use hypnotherapy to the absence of great local anesthesia and great procedures. What I do is use what you might deem to be some hypnotic language and suggestive things to increase their comfort and to allow them to believe that they have more control. So there's a fantastic, as science-based people, right? When I first started learning hypnotherapy, I just thought it was all woo-woo and a bit of BS. And I started to learn it, seeing the evidence of it. And then I met the amazing Mike Gow, who's a dentist up in Scotland. He recorded a TV program for BBC Scotland where they extracted 2 central incisors, bone grafted, and placed 2 implants without any local anesthetic. It was all under hypnotherapy. So what we know is that with careful language and empowering the patient, we can hypnotize somebody whilst they're completely awake to dial down the pain to an almost imperceptible level. Now, I'm not saying that when a patient phones up in pain, we start going, oh, swinging a watch and trying to hypnotize. What I am saying is that the careful use of language, the careful use of our tonality and the way that we are dealing with patients, you know full well that we discussed this again, right? 7% of your words are your communication. The rest is your tonality and your physiology. And you can't separate tonality and physiology. So if I get a phone call from a patient, and let's assume that I'm currently at home, COVID-19, the boys are knocking on the door, trying to get in, and I'm frustrated with the boys, that frustration comes through in my voice to the patient. So even though my words might say, now look, I'm gonna give you some really good advice, I'm saying it with a tonality because actually my focus of attention happens to be on the fact that my 5-year-old's banging on the shed quarters door. So the first thing is to make sure that your words and your tonality are congruent, they're aligned. A calm voice, a private space, no distraction, so that you're relaxed, because that has an effect on helping the patient relax. The fact that I don't not ever use the word pain. If a patient is in raging, banging a head against a wall pain, I'm going to be using the word pain. What I'm then going to be doing is using language of reassurance of the fact that I say, look, what I'm going to do right now, you're remote. I can't see you. You're not in the situation where you require antibiotics. And what we're going to do is slowly but surely, I'm going to help you so that you can reduce the level of pain and start to feel more comfortable. And you're going to start to feel more and more comfortable as you take the paracetamol and the ibuprofen. It's going to take 36 to 48 hours to really start to notice that. I'm going to check in with you tomorrow because I've got your back. And worst case scenario, we can always get you in somewhere. Well, I'm not sure we can, but I'm still going to reassure them. So it's reassuring language. Yeah. It's using positive phrases. I didn't do language with you. Can I show you a couple of slides?
Yeah,
please.
Can you do that, please? I will, if it's okay, I'll just change the slide share just for a moment. There you go. I think that's Barry's slides now. You're visible.
Hang on, mate. I tried to get dressed for this talk tonight.
That's fine. And Ian, very nice PP.
I'm the only dentist, and not even frontliners that have got decent. That's obviously not me.
Ian, what's the while Barry's setting up, a question about is there any Daisy Hood asking how long can they take pain relief every day for? Will the effect stop working over long term?
No, the effect won't stop working. There's no what's fancy word is tachyphylaxis with this. It will still carry on, but obviously there are limits from a health perspective that we shouldn't be keeping patients on maximum dose pain relief indefinitely. But I think we then have to look at in terms of hospital prescribed pain relief medication for patients with severe multiple traumas. They're on massively higher dose, longer doses than we are talking about. So normally we wouldn't be keeping someone on because we would just be getting them in to get them out of pain. Now we're in this scenario where we sometimes can't get them out of pain. It's then just a question of how long are they likely to stay in pain. I have to say, I think it is relatively short. It is that sort of, if we just took an average of a week, and we don't, although there are some studies showing that high dose ibuprofen is having cardiac impact at a week, and so we might be thinking not to do that on someone with some significant morbidity associated with cardiac problems. I think we can feel pretty comfortable for most of our patients who are generally fit and well that they're not going to be getting significant medical side effects at the doses that we're prescribing for the lengths of times we're talking about. 1 to 2 weeks is not going to do significant harm for otherwise healthy individuals. Once you've got patients who are significantly unhealthy, then I think we've got to be risk assessing that and leaning harder on urgent dental care centres to say that this patient needs to be seen because they can't take the pain relief medication that we'd like them to be on. Every patient gets risk assessed individually, don't they?
I think that makes sense, and we have to work through. Very useful. Barry, you were going to tell us a bit about the subconscious language influence principles, please, if you don't mind sharing with us.
I'm going to share this with you. Just let me just to précis this very slightly. I think there are two very important separate scenarios here. One is the fact that we are in lockdown and we're in uncharted territory of dealing with and helping our loyal, wonderful patients to deal with problems that normally in our other parallel universe, we're able to see them fairly quickly, fairly actively, right? And whilst I'm saying that there are huge benefits to be able to use hypnotic language or language patterns, it's not going to solve the fact that the patient needs blooming treatment. What it is going to do is it's going to support them, and it's going to build your relationship with them, and it's going to reduce their psychological side of the pain during this period of time. Because I know that, I live 10 minutes from my practice. If my patient's in pain, God damn it, I'm going to get down there. I can be down there within 10 minutes or certainly within the next 12 to 24 hours. So two separate issues, right? I'm not saying we can talk people out of pain for the next 3 weeks, but what we can do is use some language patterns to ensure that we're increasing their trust in us, their trust in themselves, and the trust in our systems, so that when we can see them, we can look after them. So I just thought it was worth covering that. Subconscious influence principles in terms of language, right? There's a rule of the subconscious mind, is that your subconscious mind can't process a negative, okay? Your subconscious mind can't process a negative. We did the model of communication last week, and what I said to you is we're bombarded by over 12 million bits of information per second through our 5 senses. We're only consciously aware of, it's postulated by Mihai Csikszentmihalyi, that that's about 134 bits per second. And Ian drew notice to that, which is, you know, we ignore the music, we do this, we do that. If you remember, we delete, we distort, and we generalize. Imagine that those 134 bits of information are split into between 5 and 9 balls that we're juggling. So I'm juggling between 5 and 9 chunks of information that I can be consciously aware of. That's why when I'm playing football with a broken leg, and my focus is on my teammates, the score, the crowd, and everything else that's going on, I'm deleting the sensory information that's coming into me via my broken leg. And later on in the day or in the evening, that's why most of us dentists start to feel the back pain or the shoulder pain after work. The stimulus was still there, right? So in actual fact, filling your busy mind, filling your mind with things and being active is one way of encouraging a patient to potentially dial down their perception of pain, because they're juggling balls that don't include the pain as one of their senses. That makes sense? Then when it comes to language, you can't process a negative. So if I was to say to you, Drew and Ian, don't think of a blue tree, you have to, even if it's a nanosecond, you have to think of a blue tree to understand the sentence, don't think of a blue tree. Make sense? So I didn't know this. My eldest daughter's 21 and youngest daughter's nearly 19. So when I learned this like 13 years ago, I would say things to my daughter like, hey, Millie, do me a favor, sweetheart, don't spill that drink. Now I understand that my Millie is highly visual. She's now a very accomplished artist at uni. And that internal representation, for her to process what don't spill the drink means, she has to think about what spilling the drink is. So what that means is that she has a picture, a movie, some self-talk or some feelings of what spilling the drink is, which means in her internal representation, I have effectively created her to rehearse spilling the drink. Make sense? I have a friend, I know I'm from Liverpool, I said this, that I do have a friend. She's a catwalk model, and she would be wearing a particular set of heels, particular dress, climbing up the stairs to the catwalk going, don't fall, don't trip, don't trip, don't trip. She was rehearsing this in her head, and invariably she would fall over every single time. And yet we kind of know this. You know, you've had it when you've been looking after a child. Little Johnny's never been to the dentist. He comes in and he's nervous. Well, number one, why is he nervous? He's never been to a dentist. He's nervous because of somebody else's perception, somebody else's experience, maybe peers or maybe parents, and we pick up on their emotions. His mum's a nervous patient. Little Johnny comes in nervous. Mum says, oh, it's all right, doc. I've told little Johnny not to be scared. And we all went, oh my God, you didn't, did you? Now, we didn't verbalize that, but we felt it, because we also know that when we say things like there won't be any pain, it won't hurt, don't worry, don't be scared, in order for them to understand what the other side of that sentence is, which is, I'm going to make sure it's comfortable, they have to perceive the pain. They have to perceive hurt. Now, what we're not in control of is what their internal representation is of pain. I'd never had pain anything like that when I had that toothache a few months ago. Little Johnny's never had toothache. And when he knows that he needs a fill-in and mum says, it's all right, I've told little Johnny there won't be any pain, his point of reference is when he fell off his bike, broke his arm, ended up in hospital. So we are, to a degree, capable of helping somebody form positive internal representations of what we're going to do. And the way that we do that, certainly in my practice, and I encourage everybody to at least be playful with this, is we remove negatives almost entirely, apart from when we're using them with purpose, which I'll tell you in a minute. So instead of saying, it's okay, don't be scared, don't be worried, I say, look, I'm going to make sure that you're completely relaxed and comfortable all the way through. I'm going to make sure that everything I do for you is completely comfortable. And I'm going to make sure that you stay calm and relaxed. Now, those specific phrases you're not necessarily going to use on the phone during triage. And yet you can choose to use phrases that are positive, with positive intent, and are likely to create a better internal representation. Like, I'm going to phone you and make sure I'm at the end of the phone for you, and I'm going to look after you. You take these painkillers, and what we know is that's going to systematically dial down the pain over the next day or two. And I'm here for you if you need me. And using these positive reassurances, but everybody knows this. This is nothing new. I'll skip advertising because that's the same thing. When we're using words like this, when we're using words like fear and pain, it generates this perception of dentistry, as opposed to us using things like comfortable and gentle and all of these other words that we can use. So I want you to consider that there are two scenarios here. There's the scenario where I would love you to be mindful of when you're using negatives in your day-to-day life and your day-to-day practice. Simple example, my 18-year-old cooked dinner tonight, absolutely fantastic. And she did the dishes. Previously, I would have said, sweetheart, thank you so much for doing those dishes. But what about the last one? The word but negates what came before it. So when you're explaining something to a patient and you want them to hear the message, you need to remove the word but from your conversation, so that when you say, look, I am here, I'm going to look after you, but I'm not able to do that until you can come to the practice, subconsciously, they didn't hear the fact that you're there, you're going to look after them, and you've got their back. That makes sense? So there's two language patterns. The one is, that's not the language pattern. The two is removing negatives and also considering being careful with your but. There's a whole video on that on my website for free, so I won't go in and explain it anymore. But in essence, those are the things that I would begin to employ if you're not already doing that, and be playful with it. Catch each other out gently. My 7-year-old at the time became the butt police. So she'd be like, "Oh, Daddy, you said but." And it was like, "Oh, you're right." And we'd change it. So in essence, that's where I'd want. I could start to talk to you about hypnotherapy and embedded commands and things like that. But at this level, I think just starting with those two things would make a huge impact in the positivity in your patient's mind.
I think, can I just come in on that? I think that's absolutely superb, what Barry was saying there. I think the wonderful thing about that bit with the delete, distort, and generalize, those three filters that bring us down from unimaginably high levels of input down to a manageable level, is that although that we all have the same three, how much we use each filter is different. So, you know, and I'm sure Barry will of course know much more about this than me, but you know, when we're dealing with audio digital versus audio visual and kinesthetics, and you know, how people are learning and how people take on information, that often reflects in how much they're using each individual filter and what they filter out. Most of we habitually filter out certain bits of information that don't fit with our general worldview, and so it just reinforces our worldview. But you know, the more we get to know about those individuals, the more we can know which approach is going to work best for them. And I think that brings us back to the triaging element, and one of the most important messages I think I've ever picked up in dentistry along the way, and it was from Martin Keller, and it was just a phrase of his, which was never treat a stranger. And I think, you know, the more you can get to know about an individual and understand what makes them tick, then the more likely we are to provide the right language to help them, to help themselves. And so that phone call is so important about that initial triaging of for me, you know, giving me time to, if I can, log on remotely to look up actually who the patient is, because they say, "Oh, Ian, it's so and so," and you think, not a clue. You know, give me a clue. What was the last tooth I treated? Give me something to cling to. Are you lower left 6? Are you upper 3? Give me something I can work with. Don't give me names. You know, so you know, I've got to log on and try and look at them and then get the cogs going, oh yeah, I know, I remember about that, and I remember you, and I think, yeah, this probably works best. And so if we know them well, we can start from the right angle to that patient because we've experienced in the past how to speak to them.
Do you make a note of that when you're in your patient file? Or is it?
Yeah. I mean, I will make some reference to what likes and don't likes and what works. Yeah. I don't try and categorize. I'm not skilled enough and knowledgeable enough to try and categorize individuals as to whether I think they're audio digital or.
Listen, as my guest, come on my 2-day training.
Yeah.
Because that's exactly what we teach.
Yeah. My favorite thing about audio digital was I was trying to think of the Irish lady. You probably know her. She's absolutely brilliant. Who lectures on this topic, and she was giving a lecture and she was saying about all the individuals, and she said those audio digital people out there in the audience, that voice in your head that's going on all the time. The rest of us don't have that. And in my head, I said, I heard this voice say, "Is that true?" And another voice goes,
That's this is
so
quite
profoundly audio digital.
And those of you, we've had a few questions about the urgent care centers.
Yeah.
So while we were discussing this, the antibiotics, I thought we'd get an insight from a guest I've just listened on today. I hope you can hear us clearly.
Hey, Drew, yeah, I can do.
So Vishal is one of the urgent care centers in Hertfordshire. Is that correct?
That's right, yes.
So Ian, Barry, myself, we've been talking about acute pain management today because invariably we're getting lots of patients, not we, but everyone in the industry, and they're in pain, they're in difficulty. And we've been saying antibiotics are not always the answer for acute pulpitis. Some of the questions coming from the audience have been that urgent care centers are not accepting patients if they're not being given antibiotics. Do you have protocols there of how you deal with these patients? Are these patients in a lot of stress? How is it operating?
It's funny enough, Drew, I've been dealing with this all day today, where we've actually realized that there are a few disparities between the different sections of the UK, if you like. So the East of England has their own protocol, London has their own protocol, and we're just trying to work to actually get all of this sorted out together in the most efficient manner. The problem arises is when you have people who are across areas, if you like, or patients who live in one area and see a dentist somewhere else, etc. That could potentially cause issues. However, I think one of the problems that we've actually encountered is that some patients are being told to phone 111 and they'd be given a code, for example, which is what one particular sect of practices are doing. Whereas in Hertfordshire, and this is, I think, true for the whole of the East of England, is that there is a certain referral pathway whereby you have to fill out a triage form as the GDP. That then gets transferred across to a secondary triage team, which is then passed on to us as a third leg, if you like. So effectively, the patients are being triaged 3 times. According to what's happening at the moment, the general consensus is that you should actually be prescribing 2 lots of antibiotics. Some may agree with that protocol and some may not, but it is to try and limit the amount of people sort of moving about, because obviously we're still under lockdown in essence. So yes, it's making a lot of patients very, very nervous. The biggest thing, actually, funny enough, what Barry was talking about just a little while ago, is how patients perceive things, and a lot of it is to do with what their experience is or what the experience of someone they trust is. So I've had 2 very, very, very irate and nervous parents who phoned me after their kids have fallen down, and really, really worried about everything. One of them came in and was good as gold. Mom was really worried, had to stay at home. Dad came in, was a bit chilled out, and we managed to get his child treated straight away. The child was absolutely perfect. I did another one this evening, which was a video consult of a child who had actually fallen over. No symptoms whatsoever, apart from the parents who were more symptomatic than the child. So again, this whole idea of actually, reassuring, etc., is actually really, really important, and it's very important in how we as dentists on that front line or in that line of communication communicate with all the patients, right from the primary triager, who is the actual GDP, through to the guys like myself who are actually working in these urgent care centers. My first thing, for example, with this little 4-year-old girl who'd actually fallen over was, I said to the mom, what a delightful young lady. She was smiling over the place, and all of a sudden the mom just calmed down. And I said, look, I've spoken to her. She's managed to actually, eat today. She's all nicely cleaned up. The teeth aren't mobile. These things happen. Everyone gets a bit of knocks. However, I actually finished my conversation with, you are now on my system and you are under my nose almost. Okay. So if there is a problem, pick up the phone. We're all only on the other end. So I think ending your conversation with some form of reassurance to let patients know that you're there if you need them is something that's actually really, really important. Because if you just put the phone down with just an abrupt sort of like, this is what we're going to do, and then leave it at that, patients are going to get a little bit more nervous, thinking, hang on a second, where do I go from here? So I think definitely Barry hit that on the head, saying, reassurance and positive reinforcement throughout this period is exceptionally important.
I think this is really, really interesting. Sorry, Ian, you were going to say
I just think that there's the absolute central message of this is to let patients know that we care and that we're there to help, and and give them that safety net in their mind that they're not going to be left, for it all to go terribly wrong. We are there, and although what we can do on the biomedical side of it is very limited, but on the psychosocial side of it is very, very high and can really make a difference. Vishal, just to try and confirming what you're saying there. So I'm not understanding the 2 courses of antibiotics. What can you clarify that, please? So if someone has a pulpitic pain, where antibiotics clearly have no part to play whatsoever, what happens with that individual?
Well, I mean, at my practice, we're treating them regardless, so we'll extirpate and sort that out. However, there is a slight issue with PPE. The guidance that came out yesterday, in fact, I will quote, says that urgent care, including examination, taking radiographs, or using hand instruments, extractions and suctions are not classed as aerosol generating procedure. So universal precautions should be used for this. And what they mean by that is basically you're wearing just normal mask and apron and your gloves.
Yeah.
The problem with that, however, is that if that patient coughs, there is an immediate aerosol. Okay. Yeah. So I don't think it is absolute. I think what we've got to do is, and what I'd advise everyone is that, we're an intelligent bunch. And you don't need absolute guidance. A lot of this is actually use your common sense, basically.
Yeah. So that's a really critical point, isn't it? That, we are healthcare professionals who are trusted to act within a series of guidelines to make individual judgments on individual patients' needs through our own ability to diagnose and risk assess a situation. We're not given absolute rules. We're given guidelines because we are healthcare professionals capable of working within those guidelines. And so, an individual who clearly has a pulpitic pain, any guideline that says they need to have 2 courses of antibiotics, we can easily work through ourselves and say, well, that's clearly not appropriate. We need to do the right thing. Interestingly, on the coughing element, I see the Royal College of Physicians have been doing their research, and that was there was an update of that yesterday, and they're looking to drop the phrase aerosol generating procedure and have aerosol generating event, so that it will include coughing.
Yeah, I think honestly speaking, I mean, and as I said earlier on, I've just been most of today writing a very lengthy letter to the powers that be, or hoping that the powers that be will actually see this. And that is that we've got to actually remember that across, at the moment across Essex, I've just got a list of that. There's 29 practices that have actually been given the responsibility to actually treat patients. Okay, and these are COVID and non-COVID sites. Even we didn't know that until today. There has been a little bit of information that's been shared, but it's not been shared far and wide enough for us to be able to try and coordinate a team effort. Now, funny enough, just literally about 25 minutes ago, I had a referral come in for a patient who lives in near Hockley, which is near Benfleet. So it's on the east side of Essex, effectively. And that patient was referred to us, yet there were 3 other practices. We're in Hoddesdon, so that's about an hour and a half drive. But there was 3 other practices in much less than half the distance away who are currently actually running under capacity. So we're not running at full capacity at the moment. We've got capacity to see more patients, etc. And this is where my sort of letter writing actually started off to say, well, actually, I don't think we're using the resources that we have available efficiently enough. And if we could actually standardize and simplify the whole triage system, then perhaps more people will get seen to who need being seen to. The problem that we've got at the moment is that the rate at which these referrals are actually filtering through, if you have a patient with a facial swelling and they end up with sepsis, by the time they come through to us, it's way too late to actually see them, which means that they're going to end up in hospital, which is what we actually want to avoid. So what I'm actually doing at the moment, well, it's 9 o'clock at night and I'm still at the practice. So I'm actually looking if any other referrals have come through so I can triage them myself to be able to call them in first thing in the morning. So when we start at 9 o'clock, it means we start treating patients and getting these people out of pain. One thing I'm also pushing for, which I hope will happen, is that, practices within a certain area or a certain radius can actually have the direct contact or the direct email of the urgent care center in that area. And if you can actually say, for example, Ian, if you phone me up and said, Vish, I've got this patient, got pulpitis, there's no point in giving them, 2 weeks worth of antibiotics. They're going to be in absolute agony. By the time they actually come across to you, they'll probably have a really angry pulp, which is going to be very hard to anesthetize, etc., and making the whole situation that much more complex. Bish, can you see them? When have you got some time? Let's sort it out. And in that way, I can say, right, Ian, send me all the details, but phone the patient back and say you're directly in touch with one of the urgent care centers, and we can just move it from there. So this whole process of reassurance is important, but at the moment, because it's still early days, and please don't get me wrong when I say this, the powers that be have not been sitting around doing nothing. There is a lot of paperwork that's actually involved in the background, and there's a lot of logistical planning that's also involved, to actually get this all sorted out. Yeah. But the more suggestions we can give, the more ideas that we can give as frontline workers, the better off they will be and the more efficient, hopefully, their decision-making process will be.
Get them to watch this webinar because we've spent some really good time understanding the science of not using antibiotics and the whole element of pain control. I think language is important. Vish, thank you so much for coming in and giving us some insight into this, because it's very useful and actually reaffirming some of the things we said on this live stream. It's absolutely brilliant. So I appreciate that. I got Vish in as just, while the discussion was happening, because there were questions coming through, and I hope our viewers got some of that insight as well. It's really good to hear about the acute management from your end as well, Ian. And I love seeing pictures of brain. That's what I've been doing for the last couple of years. And all this.
So close to it when we're working, but we don't. We're not allowed anywhere near it.
You're only one slip away from it.
Yeah.
And do it. But isn't that amazing? Because what I'm now seeing on screen, Ian, you talked about the science behind it. You talked about the neuroscience and everything. Barry, you talk about language and how it relates to science. And Vish, what you say is the practical implication of that acute management and how you do it, especially the reassurance aspect. The antibiotics are the hard bit.
Basically, you've had 2 people waffle on about the theory of it, and one person turn up and say, "This is actually how we do it."
Yeah.
Sounds like the perfect NHS way of handling a situation there.
Thank you for being one of those people that are actually able and willing to see patients, mate. I'm nowhere near Essex, but I'm grateful on behalf of them.
Yeah, no, thank you.
It's our pleasure, and to be honest, it's also our responsibility. And we've got to represent and help wherever we can. Drew's doing an absolutely phenomenal job, Drew, by bringing everyone else together into, to coming together as a community and stuff. So, I salute everyone who's actually put in time in whatever way it is, because we're sitting around. Well, some of us are sitting around just thinking, what do I do next? Thank you to Dentinal Tubules and all the speakers as well. It's fantastic, and please keep your spirits up. Most importantly, just stay safe, because we need everyone on the other side of this.
Yeah, absolutely.
So
absolutely.
there are a few other questions on the website. I'll send you guys the link. So because I think we're running short of time, if you mind having that chat, because hopefully people have found it very informative.
Drew, sorry, could I just say one thing? Just with regards to the referrals across east of England, okay? There seems to be a lot of confusion about how to refer within the east of England. So this is in particular aimed at those people who might be listening that are in the east of England. Please feel free to share this. A lot of people haven't actually looked at, or may have missed, the emails that were actually sent out to all the practices with regards to how to refer. If you can't find it and you're based in east of England, please just email me on our practice website. I don't know, Drew, if you want to actually put that up on the comment section or anything like that. Just put our email address up. I've actually put it on the comment section on the Tubules website as well, where you asked for it about the urgent care centres. But for those of you who are listening and are in the east of England, it's info@dentality.co.uk. And just email us, and I will get one of my receptionists to actually directly email both the documents that you need to fill out immediately. So just save it as a document on your desktop, so you can easily fire across those referrals to the urgent care centre. All the details are on it, so it'll hopefully just make it a bit easier and quicker for all of you.
Great. Thank you very much. I think that we appreciate that. Thank you so much, and for sparing the time, working hard. Talking about keeping spirits up. Last week, Barry, you did end up with a story which you'd tell us about physiology. And we did say you'll tell it to us this time. I know this story, the importance of physiology and what it did, really.
We should roll it on to next week.
But I can't give you the time today. I think next Thursday, because this Thursday are Barry's Hour. Barry's Hour Thursdays. I think next Thursday, could you start with that story? Because I think it's phenomenally important. And in fact, watching Vish, I can see he's doing that already. So if you listen to the story,
Drew, I watched that last time, and I watched the TED talk about high power poses. Can I just say that I have been way ahead of that? That has been my hallmark. Photos, about 1,000 photos of me doing that somewhere at the background of every lecture theatre I've ever been in.
Good man.
So the high power pose, I'm way ahead of it, way ahead.
Brilliant. I'm glad you picked it up before Amy Cuddy did. That if those of you missed that, just go back to Tubules Live Aid lectures and watch Barry's. Talking of that and comforting patients, I'm just going to finish on one other thing that we did speak about last week. We were discussing, if I can just share my screen, if computer will let me, about Barry's comfortable handle injection technique. And I was telling you, this is a really, really good place to be to know about patient care and acute care management. Well, Barry's done a special offer for us. Instead of the usual 49 quid, there you go. Special Tubulites price of 29 quid for it. And I think it's worth, because it brings a lot of the stuff we talked about today into more practical application. It's all about comforting patients through pain, through distress, through difficulty. Thank you very much for all of you to come on. Ian, thank you so much for talking about it. Barry, as always, is great to listen language. Vish, thank you so much, because we're comforting patients at Tubules. We're making sure people at Tubules are not in pain. Instead, they're all in pleasure, in high spirits, ready, happy, and together.
Together.
Another Tubules Live together. Yep, and that's right. So I'm going to finish again with our Tubules Together video before, and then we will see you tomorrow for the Geek Out Gang at 2:30, and on Saturday at 5 o'clock we're actually doing a Tubules Live together on cooking. Rebecca Howarth coming through from Optiden. She's been on MasterChef. she's going to teach us how to make a chocolate pizza. Now that will be fun.
And can I put a request in?
Yeah,
Chili
go on.
paneer, please, Drew.
Sorry?
Chili paneer, please.
Chili paneer.
Yes.
Chili paneer, I made it. I'll put that
Paneer.
picture up. Yeah.
Good.
Brilliant.
Chili
It has been awesome. Thank you so much. This is a chili paneer filled evening. Thank you. There we go.
Isolation doesn't mean loneliness.
Uncertain doesn't mean unpredictable.
Challenges mean opportunities.
Time out means a time to reflect.
A time to come together.
A time to work together.
A time to support each other.
A time to inspire each other.
A time to change the way we think together.
A time to learn new things together.
Time to educate each other.
A time to gain personal mastery.
Time to gain a financial mastery.
A time to gain clinical and professional mastery.
A time to believe.
Believe that together we will come through this.
Believe that to restart will reignite a new beginning.
Because when we work together,
We will
Motivate, grow, thrive together. Dentistry together.
Together.